Right. Good afternoon, everybody, and welcome to the first deep dive hematology session for the year 2024. I hope you've all had a lovely break and rest and have started this year on a good high. And I hope you do enjoy all the sessions that we're coming up this year. Has been very good the last 2 years. We've learned a lot, have gained a lot of insights from other centers, and I hope it continues into this year as well. I'd like to start by thanking Janssen for sponsoring both the session and the speaker. Thank you very much. It's much appreciated. The talk today will be given to us by Dr. Justin Dutoy, and I think most of you know him well or have at least heard him speaking. He's going to talk on highlights of ASH 2023 with a particular focus on CLL. Justin's a clinical hematologist at the Wits Donald Gordon Academic Hospital in the hematology and bone marrow transplant unit. He has a passion for collaborative projects in best practice hematology in South Africa. Before I give him the chair, can I just bring up a few of the housekeeping notes? All the recordings can be found on www.bloodessay.org.za under resources deep dive. If you have any questions, please add them or comments to the chat box during the talk. You can email requests to be added to this mailing list to melanie.davids@uct.ac.za. CPD points will automatically be submitted to the HPCSA for each attendee in South Africa, but please make sure you're attending with your own registered Zoom account and not in a group, otherwise you won't get the CPD point. If you have any queries or require a certificate for another country, please contact Melanie. You need to attend for at least an hour to qualify for a CPD point. Blood Essay and the speakers value your honest feedback. Please complete the anonymous feedback survey at the end of the Zoom meeting. As you know, this is anonymous, so they are unable to respond to requests requiring a response made in the comment section. If you do want a response, communicate directly.
Meeting.
Sorry?
From his office, probably. Like some sort of.
Can you mute your mics, please? Got somebody in the background. Thank you. Thank you very much to everybody. I hope you enjoy the session. And Justin, over to you.
Thank you so much, Dr. Philip. Good afternoon, everyone. So I'm going to talk about highlights of ASH, but I'm not just going to speak about CLL, because I think going to ASH and speaking or focusing just on CLL is very difficult, because there's a lot of topics that that I've been exposed to and learned that I want to share. And I must say that these topics are actually just, it's not a lot that I'm sharing today, but there's a lot that I've learned. And I hope that each and everyone gets an opportunity to go to ASH one day. So the agenda for today would be to focus on the new evidence for ibrutinib in CLL. And then secondly, I'm going to focus on a thing called the CHARM score for the older patient. And this is now in the context of bone marrow transplant. And then thirdly, I'm going to focus on a bit of individualized dosing of anti-thymocyte globulin, the first prospective trial that was done. And then lastly, I'll focus on myeloma, the results of the Perseus trial. So I'm first going to talk about CLL, so about the GLOW trial. So this is where ibrutinib and venetoclax together versus chlorambucil and obinutuzumab or Gazyva was compared to each other with a 57-month follow-up. Now, this was a randomized phase 3 study of first-line treatment with fixed duration of the ibrutinib venetoclax versus the chlorambucil and obinutuzumab in patients with untreated CLL, aged 65 and older or younger than 65, and a cumulative illness score of above 6 and a creatinine clearance of less than 70 moles per minute. So not the fittest patients available. And then just note, no deletion 17p or TP53 mutation, and the ECOG score of between 0 and 1. So they randomized them in a 1-to-1 fashion. The total was 211 patients. They looked at ibrutinib, or they gave ibrutinib for 3 cycles lead-in, followed by the ibrutinib venetoclax for about 12 cycles, versus chlorambucil and obinutuzumab. The primary endpoint was progression-free survival, independently assessed from obviously the sponsors, etc. And then secondary endpoints was to look at undetected MRD, so minimal residual disease rates, response rates, overall survival, and then time to next treatment, and then safety. So what the results revealed was for first-line ibrutinib and venetoclax, there's a continued progression-free survival in the ibrutinib venetoclax arm. Okay, so the median follow-up is 57 months. The 54-month progression-free survival rates were 66.5% for the I plus V and only 19% for chlorambucil and obinutuzumab. And if you stratify these by the immunoglobulin rearrangement status, the progression-free survival rates were 90% for mutated and 59% for unmutated versus 40% for mutated and 8% for unmutated in the chlorambucil and obinutuzumab group. So there's a definite continuous progression-free survival benefit at 57 months of follow-up with ibrutinib venetoclax fixed dose treatment. Then it's also shown an overall survival benefit at a 57-month follow-up. So the ibrutinib venetoclax reduced the risk of death by 55% versus chlorambucil obinutuzumab with a hazard ratio of 0.453, quite significant. And then the estimated 54-month overall survival rates, 84.5% for the patients treated with ibrutinib venetoclax versus 63.7% for the patients treated with chlorambucil and obinutuzumab. Now looking at time to next treatment. So there was superior time to next treatment for the combination of ibrutinib with venetoclax in the GLOW trial. So it prolonged the time to next treatment and reduced the risk of requiring second-line therapy by 82% versus the chlorambucil obinutuzumab group. And this is quite significant. Then, if we look at the Captivate trial, I'm just going to move forward and just show you the study information. So it was an international multi-center phase 2 study evaluating first-line treatment with ibrutinib with venetoclax that comprises of 2 cohorts, fixed duration and MRD directed. So per protocol, patients with progressive disease after the completion of the fixed dose I plus V in the fixed dose cohort or the MRD cohort placebo arm could reinitiate treatment with single agent ibrutinib. And patients with progressive disease more than 2 years after treatment completion in the fixed dose cohort could be retreated with fixed duration regimen. So 3 cycles of ibrutinib lead in, and then 12 cycles of ibrutinib plus venetoclax. Now coming back to the results, so they showed durable responses within 5 years of follow-up. So the median time of this study was 56 months for the high-risk group. 54-month progression-free and overall survival rates were 70 and 97% respectively, very good. And then the best response rates were unchanged for the 4-year follow-up analysis. So with up to 5 years of follow-up data, fixed duration, ibrutinib with venetoclax continues to provide a deep remission with clinically meaningful progression-free survival, including in patients with high-risk genomic features. And those ones obviously include deletion 17p, complex karyotype, unmutated IGHV. Okay, then moving forward. So then this is now the UK FLAIR study, okay? And that was where they looked at first-line ibrutinib plus venetoclax with MRD-directed treatments versus, and they compared it to FCR, fludarabine, cyclophosphamide, rituximab. And the ibrutinib venetoclax arm led to way better improved progression-free survival. So the median follow-up was 43.7 months. That the disease progression or death occurred in 12 patients in the ibrutinib venetoclax group and occurred in 75 patients in the FCR group. And the hazard ratio was 0.13 and quite significant. And at 3 years, 58% of the patients in the ibrutinib venetoclax group had stopped therapy owing to undetectable minimal residual disease. So MRD-directed therapy improved progression-free survival as compared with FCR. Now you're just going to ask me, what is MRD-directed treatment? So I'm just going to quickly summarize it for you. So what they did was they did peripheral blood MRD assessment, which was at 12 months, and then they did 6 monthly, and if negative, it was repeated at 3 months, and then at 6 months in peripheral blood and bone marrow. If all were MRD negative, then the duration of the ibrutinib and venetoclax was double the time between the start of the IMV and the initial MRD negativity in the peripheral blood. So the median duration of treatment was between 2 to 6 years. Okay. Then we looked at the IGHV status, and it doesn't seem to matter. Okay, so even in this UK FLAIR study, if you used ibrutinib with venetoclax, your mutational status didn't matter. You can see in unmutated, your curves looks quite good versus your mutated as well. And then you also had a better or favorable overall survival. So death occurred only in 9 patients in the I plus V group and in 25 in the FCR group, okay? So the 3-year overall survival was 98% with I plus V and 93% in the FCR group. The overall survival appeared to favor the I plus V group as compared with the FCR in patients with unmutated immunoglobulin rearrangement, but not those with mutated. At 3 years, 58% of the patients in the I plus V group had stopped therapy owing to undetectable MRD. So overall survival results favor the ibrutinib with venetoclax MRD-directed treatment versus the FCR treatment. Then in terms of safety concerns, so as we all know, ibrutinib can induce atrial fibrillation and a bleeding diathesis and also hypertension. But so in the earlier cohort of the FLAIR trial, they had 9 sudden deaths were reported more frequently in the ibrutinib than with the FCR, but afterwards they did stricter monitoring for cardiac-associated risk factors. More cases of atrial fibrillation and hypertension in the ibrutinib venetoclax group were reported than in the FCR group, but these results did not translate into an increased risk of sudden death. And severe infections were more commonly reported in the FCR than in the ibrutinib venetoclax group. And then, of course, tumor lysis syndrome were more common in the ibrutinib venetoclax group, but only a single case was reported. So in terms of safety, the combination of I plus V was well tolerated and no new safety signals were observed. Okay, then I thought I'll just show you, because the trip to San Diego was about 25 hours flying. It is very far. And these pictures were taken from, obviously, from flying. And this was over Iceland. This was at the edge of Iceland, just exiting Iceland. And then these pictures were taken actually of Greenland. So we also flew over Greenland. And you can see the ice blocks in the ocean. It's really beautiful. Then these pictures were, because the flight was Johannesburg to Amsterdam and then Amsterdam to Salt Lake City. So this is the Salt Lakes of Salt Lake City. You can see a huge salt lake at the end. And then we were surprised by some snow in the mountains as well, which is really amazing. And then you take a flight from Salt Lake City to San Diego, and the weather changes entirely. This is upon flying into San Diego. You can see what it looks like, a bit more tropical. And then this is the convention center. It is really big. And yeah, it's just, there's so many people. And next to the convention center, there's about, I think, 6 hotels that also that you have to walk to receive some lectures. So between lectures, you can walk easily about 20 minutes between sessions. So that's just giving you some sort of an idea how big ASH conference is. Now I'm shifting gears and I'm going to what I also learned at ASH, and this was now back to the transplant kind of like context. And I'm going to talk about the TROM score, which is the Composite Health Assessment Risk Model for older adults, because all of our transplanters get confronted with whether we should go ahead to transplant for the older patient. And this was a new milestone in predicting non-relapse mortality in older patients receiving an allograft. So the study objectives of this paper or this study was a composite health assessment risk model, or CHARM, for 1 year non-relapse mortality. Secondary objectives was the influence of CHARM on 1 year outcomes. So that would be overall survival, frailty, disability, nursing facility admission, toxicity, quality of life, cognitive decline at day 100, and then, of course, the incidence of acute and chronic GVHD at day 100, overall survival after acute GVHD. So the eligibility for this was age above 60. You must receive your first allotransplant. You should be eligible for allotransplant per your institution, and it can be English, Spanish, or Mandarin speaking. And the exclusion was that you received a prior allograft. Now, the key baseline characteristics, there was about 1,105 patients included in the study. So the median age was 67, 64% were male, 89% were white versus 4% African American versus 4% of Asian. Then the disease groups, mostly AML, followed by MDS and myeloprolif. And here you can see the disease risk index was mostly intermediate at 69%. The donors were mostly matched unrelated, followed by haplo and then HLA identical sibling, and then 8% with a mismatched unrelated transplant. In terms of conditioning, the majority, 68%, received a RIC, reduced intensity, versus non-myeloablative and then myeloablative. And the GVHD prophylaxis was and 53% tacrolimus plus other, or cyclophosphamide. I assume that that was post-transplant Cy. Now, the characteristics of the patient health variables to create the TROM score that was used was age, albumin, the comorbidity index, the walk speed, the MOCA cognition assessment, weight loss percentage per year, your activities of daily living, the PROMIS depression score, the PROMIS physical functioning score, your Konofsky performance status, your fall score, CRP, and the numbers of treatment that you're basically taking. The outcomes was that non-relapse mortality was 14.4% at 1 year, your survival was 71.7%, and relapse rate 25.3%. So from this TROM score, they could see that if you had good cognition, a good Konofsky performance status, or walk speed and albumin level, that was good markers of prediction for outcome. But if you had a raised CVP, if you had weight loss, an extreme age, so more older, and you had a higher comorbidity index, that was negative markers for being contributing to more non-relapse mortality. So then they did a multivariate regression analysis, and they saw that if you had a lower albumin level, that you had a higher risk for non-relapse mortality. If you had an increasing age, you had a high relapse mortality. CRP levels, if it was high, you had a high non-relapse mortality. Higher comorbidity index led to a higher non-relapse mortality. And of course, MOCA score, if it was lower, it was, if you had a higher MOCA score, you had a lower non-relapse mortality. And then weight loss, if you had weight loss, that led to a higher non-relapse mortality. So this is what they looked at. And then you can stratify your score into low, intermediate, and high. And the overall survival at 1 year, you can see the low score had the highest survival. And if you had a high score, you had the lowest survival. And then if you compare this to the disease risk index, the hazards ratio was actually higher than for disease risk index score, and it was significantly so. So the conclusion was that the CHARM score is the first prospectively established and comprehensive tool to risk stratify non-relapse mortality at 1 year among older patients that receive transplants. It may increase referral to transplantation. It does establish a new framework to facilitate maybe novel strategies to reduce the non-relapse mortality, complements the disease risk index in estimating survival, and it outperforms physician prognostication, and it will be tested in the future to predict morbidity and functional trajectories after transplant. So we certainly would like to incorporate this CHARM score in our assessment for patients for transplant. Okay, then back to more pictures and San Diego. So the weather wasn't too bad. I think every day the morning temperature was around probably, I would say 10, 12 degrees. And the day went up to 15 to 18 degrees because it's their winter. And on the left, you can see the Gaslamp Quarter. So this is directly just opposite the convention center. And down this road, you can get bars, and you can get all sorts of restaurants. It's really amazing. They sell a lot of different seafood and also Mexican cuisine. On the right, I went for well, this was to combat jet lag, because let me warn you, jet lag will be an issue when you go. After a 25-hour flight, you wake up 2 o'clock in the morning, and then you feel extremely awake and hungry, but then you just iron your shirts for the next day because you can't fall asleep. But then, of course, when you go to the conference center, then you would fall asleep. Anyway, that lasts for about a day or two until it goes away, and then you have to fly back just as you get used to the time difference. Now, on the right, I went for a morning run, about a 6-kilometer run, all along this road, all the way to the convention center and back. It's really lovely. And then you can also go to the USS Midway Museum. That's really great. And then also they have the Star of India ship that you can have a look at. Now, second last kind of like focus point for this afternoon. I think this is very important for the transplanters as well, and certainly something that that made me think. So here they looked at, in actual fact, just to take a step backwards. So in allogeneic transplant, when you condition patients, you have to give them anti-thymocyte globulin, and that is to prevent graft versus host disease, but also graft failure. And then we usually dose these patients. They usually get 4 dosages of a cumulative dose of 10 milligram per kilogram. We also do that in South Africa, even with our Campath in the bag. But this trial looked at individualized dosing of ATG. This is now in the pediatric population with unrelated allogeneic transplantation. And this was a single-arm phase 2 clinical trial and also prospective. Now, just to give you a bit of background, so anti-thymocyte globulin, which is used in the conditioning of stem cell transplantation to prevent graft versus host disease and graft failure, has highly variable pharmacokinetics. And overexposure to anti-thymocyte globulin leads to poor CD4 T-cell immune reconstitution, which is associated with inferior overall survival. So this group hypothesized that individualized anti-thymocyte globulin dosing would actually promote earlier CD4 immune reconstitution while still preventing GVHD and graft failure. So here they reported a prospective single-arm phase 2 clinical trial that was done in the Netherlands, in Utrecht, and that was to investigate the individualized dosing of ATG for unrelated allotransplants. The anti-thymocyte globulin dosing was based on body weight, absolute lymphocyte counts before the first dose, and the stem cell source, with cumulative doses ranging from 2 to 10 milligram per kilogram. So I just mentioned that the conventional dose cumulatively is usually 10 milligram per kilogram. Now, patients younger than 18 years receiving a first transplant with a T-cell repleted graft for any indication and a Lansky or Konofsky performance status of at least 70% were eligible for inclusion. The primary endpoint was CD4 immune reconstitution. The primary endpoint needed to be met in 38 of the 53 evaluable patients with no death, relapse, or graft failure before day 100, and toxicity was registered according to the common terminology criteria for adverse events. Now, just to give you a rough idea what this table looked like and how they approached the ATG individualized dosing. I know this might be projecting a bit small, so I'll just read the heading. So you can get body weight, it's the absolute lymphocyte count, then the cumulative dose, milligram per kilogram, the starting day of when you start the ATG versus the number of doses, and then finally the daily dose that you should be using, milligram per kilogram. Now, as an example, so if you were 25 kilograms and you had an absolute lymphocyte count of 2, then you would have a cumulative dose of around 10, okay? Let's say you were 60 kilograms and you had an absolute lymphocyte count of 0.1, so that's very small. You must get a cumulative dose of 5 milligram per kilogram. So you can see that they've adjusted the dosages around, okay, based on the actual body weight and absolute lymphocyte count. And this data was kind of like generated by a PK model that the Dutch actually put together for ATG in their population. So the results. So firstly, they showed that most patients, so that's 81% at day 100, achieved the adequate CD4 immune reconstitution. Unfortunately, they didn't have the comparative arm here. The comparative arm was actually the historical cohort, and that was 51%. Okay, it's not written here, but I hope you guys believe me, but it was 51%. Then looking at stem cell source, there was no difference between bone marrow and cord blood, okay? And then they looked at grade 2 to 4 acute GVHD. There was no difference between the historical control and the intervention. So red is the historical control and blue is the intervention. That's the individualized dosing. Then looking at moderate to severe chronic GVHD, they showed that the historical control had more rates of moderate to severe chronic GVHD, completely what we would not expect because they would get higher doses or exposure to ATG. And then graft failure rates would also be higher in the historical cohort. So this was really food for thought. So the findings is that between July 2015 and August 2018, 58 patients were included in the study, of which 51 were evaluable for the primary endpoint. The median follow-up was 25.6 months, and the median age was 7.4 years. 50% were male, and obviously the rest were female. CD4 immune reconstitution was reached in 41, so 80% of the evaluable patients. Hence, the study met its primary endpoint. There was no difference in CD4 immune reconstitution between patients who received different stem cell sources. So that's cord blood versus bone marrow. The most common grade 3 to 5 adverse events were infections, followed by immunological disorders. 2 patients died of GVHD, which might be indirectly related to the intervention. So the interpretation of the trial was individualized dosing of ATG led to a significant improvement in early CD4 immune reconstitution without increasing GVHD rates and graft failure rates. and the promotion of early CD4 immune reconstitution by individualized ADD dosing might improve outcomes for the transplants. Then all the South Africans attended, just to shift gears again, the Ernest Beutler lecture and prize, because Johnny Mashlangu, our very own Johnny Mashlangu, received this honor. And we had to go and listen to him. It was a fantastic talk. And quite frankly, super inspiring. So, and then of course, we had to meet other colleagues. So Dr. Catherine Antle, we had some tacos in somewhere in San Diego. She's working currently at the Dana-Farber. And then I also met up with Irma, who's currently in Canada. And then another inspiring individual was Dr. Mizrahi. So she spoke in one of the presidential symposia about NK cells. Now, I think NK cells is probably going to be the future of cellular therapy. And I'll just quickly touch on some things about NK cells. So NK cells for allogeneic CAR therapy. Advantages of using NK cells is that it's allogeneic, so there's no GVHD. It's off the shelf and has lower cost. The killing is CAR-mediated and it has innate receptors. It's usually antibody-dependent cellular toxicity through binding of CD16 on NK cells to antibody-bound target cells. And the safety is that there's no cytokine release syndromes or neurological syndromes. Disadvantages, it has a limited lifespan in the absence of a cytokine support and unclear best starting population for manufacturing. Now, just to show you some results of the first in-human trial where they transduced a CAR into a cord blood-derived NK cell. And they used this in lymphoid malignancies. And this was around, I think, 37 patients. And the 37 patients actually responded really well. So you can see that the NK cell therapy results in durable responses in patients with lymphoid malignancies. It's very small numbers, but it was a positive signal for a positive direction for CAR transduced NK cells. So the big question is whether NK CARs will be the future, but only the future will hold or will tell us. Now, just to say that they also tested this in classical Hodgkin, and they also saw great responses in patients, yeah. And this was only a single patient. So we will wait and see what the future holds. Then for the last little bit of this afternoon, I'll just focus on myeloma. So this was also, this was Dr. Sonneveld from the Erasmus Medical Center in Rotterdam. And he presented this paper that was published in the NEJM about upfront first-line daratumumab in combination with bortezomib, lenalidomide, and dexamethasone for multiple myeloma. So it was a phase 3 trial. They randomly assigned 709 transplant-eligible patients with newly diagnosed multiple myeloma to receive either subcutaneous Darzalex combined with Velcade, Revlimid, and dexamethasone induction and consolidation therapy, and with lenalidomide maintenance, or just VRD induction and consolidation therapy, and in lenalidomide therapy alone. The primary endpoint was progression-free survival, and the key secondary endpoints were complete responses or better and minimal residual disease negative status. So the median follow-up is 47.5 months. The risk of disease progression or death in the DARA-VRD group was lower than the risk than in the VRD group. The estimated percentage of patients with progression-free survival at 48 months was 84.3% in the DARA-VRD group and 67.7% in the VRD group. Hazard ratio was 0.42 and quite significant. The P value crossed the pre-specified stopping boundary. The percentage of patients with a complete response or better was higher in the Dara-VRD group than in the VRD group. So that's 87.9 versus 70.1%, as was the percentage of patients with MRD negative status. So 75.2% achieved MRD negativity with Dara-VRD versus 47.5%. Death occurred in 34 patients in the Dara-VRD group and in 44 patients in the VRD group. Grade 3 or 4 adverse events occurred in most patients in both groups, the most common being neutropenia and thrombocytopenia. Serious adverse events occurred in 57% of the patients with Dara-VRD versus 49.9% in those in the VRD group. So the conclusion was that the addition of subcutaneous Darzalex to VRD induction and consolidation therapy and to lenalidomide maintenance therapy conferred a significant benefit with respect to progression-free survival among transplant-eligible patients with newly diagnosed multiple myeloma. And then you can see this beautiful Kaplan-Meier graph. So we're comparing the Dara-VRD with VRD. And then the forest plot, you can see that that Dara-VRD actually favors most most groups, if I can put it like that. And that is my talk for this afternoon. I don't know if there are any other questions.
Thank you very much, Justin, for such an interesting overview of a few topics and not just CLL. Your
Yes.
photos from the plane are actually amazing. I'll just go to the chat and see what we have. Jacques says, pity the comparator for the first trial were the venetoclax. The ibrutinib with venetoclax. That the comparator was not a great comparator. I mean, chlorambucil and butinumab is not so great. I agree with Jacques. Andrew says the FLAIR trial compared it to FCR and looks good. And you did talk about the FLAIR trial, and I plus V was definitely far better than FCR. Amplify uses acalabrutinib with venetoclax with or without obinutuzumab versus FCR-BR. Reporting date still awaited. I think that may take some time to come through. Suppose many of these trials were designed in the era where chemoimmunotherapy was still standard of care. Hopefully, future trials will compare the various combinations of targeted therapy. My biggest problem working in public sector hospital is that we don't have access to any of these newer agents. I mean, we are able to get bendamustine now for some of our patients, but it's really restricted to about 5 patients. And I think that would be what would be happening in other centers here. Rituximab is freely available. We have fludarabine, but they're all losing their usefulness, I think, in trials. We have no access to any of the BTK inhibitors, which is freely available, I believe, in the private sector here. I'd just like to ask anybody else from the public sector whether they have access to any of the BTK inhibitors for second-line therapy. Let me not make it first line. Let me ask for second-line therapy in patients with CLL. Okay. Got a few answers here. No, nobody seems to have any access to it. We also don't, so I'm not special. The question, and what maybe it's me alone or it includes others, is that when we listen to many of these studies and trials, we are disappointed because we are still so far behind on what is available in the public sector. There doesn't seem to be much hope of us being able to ever catch up and give them newer therapies. Any thoughts on that, Justin? What do you think the future holds for us now that NHI is also going to come in, I believe?
That's a very difficult question. I think even patients that are in private sector, I think sometimes you struggle with access depending on their medical aid and the tier that they're on. I think certainly, I mean, ibrutinib with venetoclax is a very, very expensive kind of combination in our context. I don't know about Andrew McDonald's, what his experience is, but I think we get difficulty just getting auth for ibrutinib monotherapy. What about ibrutinib with venetoclax therapy? Goodness.
If you don't mind me asking, how much does it cost in the private sector for both?
Both will be exceptionally expensive. I can't remember offhand, but the ibrutinib is, I think it's more expensive than the venetoclax. So
I thought it was the other way around.
Yeah, it's quite.
We have many new young hematologists, and it might just be good for them to know. Yes, Andrew, you can jump in. Please join.
Yeah, so just so both acalabrutinib and ibrutinib cost around about 75,000, give or take, per month. AICF, which is the foundation obviously funded from pharma, will cover 25% of that. So, but it's still, and that's obviously long term. Venetoclax is obviously interesting because as we've discussed on these forums before, the headline dose is 100,000 rand a month for 400 milligrams daily, but obviously everyone is using azole therapy to reduce that cost to a quarter. So you're looking at 25,000 rand a month. Any problems there that AICF is then a problem politically, legally, etc., to cover that copay cost. So combining, if we had to combine the headline doses, we're looking at 175,000 rand a month. I actually haven't managed to get anybody onto a dual combination. The problem with using the venetoclax with the reduced with the azole is really the issue is that then you're also having drug interactions with the azole with the BDKs, and that the most stable and predictable of the BDK inhibitors in terms of azole use is actually zanubrutinib. Acala and ibrutinib are much more difficult to predict. I mean, there are some people who are using azoles with that reduced dose. So it's kind of one of these up in the air things still at the moment, but headline cost 175,000. That's without adding in the anti-CD20 monoclonal, whether it be obinutuzumab or rituximab. Yeah, I mean, even in private, that's unsustainable. And just to say, we've had a lot more pushback this year from medical aids. We really are struggling with. We had people on last year. This year, the co-pays have skyrocketed. So I think we'll be losing even less of these in private this year.
Sandro, no, I know. Well, I was under the impression that we would never ever be able to access it. It looks like even private sector is also going to be struggling with the CLL. It's not just CLL. I find that we have the same problems even with treating non-Hodgkin lymphomas and myeloma, which was your final part of your talk. I know they're going to talk about myeloma. I think it's next week. So I don't want to say too much about it, but a combination of DARA, VRD is great, except that public sector, we don't have we don't have any access to daratumumab. I assume it's the same for the other centers. And even Velcade is restricted to specific numbers of patients. I know it's part of the EDL, but even in our hospital, we don't have easy access to Velcade or bortezomib, so it becomes a problem. I'm not sure if Jacques, you have access to Velcade easily.
We do have access reasonably routinely. We have to still motivate per patient, and we are getting some pushback with the budgetary constraints. But so far, for young or transplant eligible patients, we've been managing to get hold of it.
So can you use it on all your transplant eligible patients?
Yes, we try very hard. So yes, so we staying on indication on the ML, we tend to get it approved.
Very interesting, because we are still using cyclophos. By the way, we don't have lenalidomide. We are still using thalidomide. I'm not sure which one you have access to.
We basically, we're using lenalidomide now routinely.
The cost difference is minimal, but with the number of patients we have, we are unable to use lenalidomide, even though we've tried. Any other questions from the audience? Just put up your hands, please. Don't have to chat. I agree with you, Jacques. We need to really improve our clinical trial network at all centers. We are fortunate right now that we do have an ongoing trial on CLL, but CLL is not one of our major conditions that we see at Baragwanath. I think last year we saw about 17 patients with CLL out of the 420 new patients that we got. So it's really a small number. Yes, Jacques, go ahead.
I just wanted a question for Justin regarding the Perseus trial in the transplant eligible myeloma patients. Did most of the patients, I mean, in terms of most of the patients that go on to transplant, did they give any data on that? Was it equal between the groups and they all went to transplant, or was there any data on that?
Sure, let me just, I can't remember offhand, but I'll quickly check the paper.
See, Simon says in the chat box, most went to transplants. So I just wanted to see if they, it would be interesting just to, if they're all converted to transplants. So.
Okay, but thanks for that answer. Simon, Brett.
Equal numbers, Barclay, so that's great. Any other comments, questions from the audience? Otherwise, it once again leaves me to thank Janssen for sponsoring, and thank you very much, Justin, for keeping us abreast of the new findings from ASH last year. And as you mentioned, I would also hope that all of us get a chance to go to ASH one day. Guys, thank you very much. I believe the talk next week will be on myeloma. I stand to correction, but I think that's what I read. And I hope that we shall all meet again next week. Thank you once again for joining.
Thank you.
Good afternoon all.